is a man who is very known to me. First is MBBS and MD from Calcutta University, then joined health service, then MES, and retired as professor from Medical College, Calcutta. And I also retired from the same institution 1 year after him. He is a man full of knowledge and humor, a man full of humor, so I like and respect him very much. So over to you, Pradeep.
Thank you, Sudha. I want to thank organizer of Masterclass of ICP West Bengal for inviting me as a chairperson of this important session of adrenocortical disorder, a clinician's approach. Speaker is none other than Professor Subhankar Chowdhury. He is an endocrinologist of national repute. I had the opportunity to be with him from 1994 to 2005. I have seen him growing in a single institute with the growth of the knowledge and the growth of the department. Adrenocortical disorder in a prima facie, you can make a provisional diagnosis by 15 or 20 minutes interview, but to arrive at a scientific diagnosis logically is full of with ifs and buts, and there is stumbling, many stumbles. So to do justice to this subject, we usually a man of vast experience and wisdom is always welcome. He is Professor Subhankar Chowdhury is professor and head of Department of Endocrinology, IPGM, and I will request Professor Chowdhury to start his deliberation.
And thank you, the chairperson, for the kind words of introduction. It's a humbling experience to be here amongst so many senior physicians. Now, the topic of adrenocortical, let me try and share my slides. So adrenocortical disorders are not very common problems that physicians would see in everyday life. They are uncommon, but they are extremely important. And as Pradipda has also pointed out, that sometimes getting to the bottom of the diagnosis is difficult. So with these, let me go into the slides. We remember a little bit of the anatomy, that adrenal cortex has 3 layers. The outermost, zona glomerulosa, secreting mineralocorticoid. Then we have zona fasciculata, which secretes glucocorticoids, and the innermost reticular is secreting androgens. And of course, inside that, we have the adrenal medulla, which we are not touching today. In terms of the disorders related to these various layers, they may not always come up specifically as from one layer or the other, especially when you are talking about deficiency. But broadly, we have hyperfunction, and that's something I think peculiar in endocrinology, that when you have a diseased organ, normally you would think that the disease only leads to hypofunction, but in adrenal for endocrine glands, you can have both a hyper and a hypofunction. So, and apart from that, there is an entity of incidentaloma, which is of course a term that we have coined over the years. You have incidentaloma elsewhere also. So you have adrenal incidentaloma, where you have performed an imaging for some other reason, someone is complaining of pain abdomen, and then you land up seeing an enlarged adrenal gland, which typically, ideally, would not be a cause of the symptom or sign for which the imaging was performed. That's what you call an incidentaloma in any organ. So when we talk of hyperfunction of the adrenal cortex, we do have primary aldosteronism. That's from the glomerulosa, zona glomerulosa. And you can have, of course, the more common Cushing's syndrome, overfunction typically of the zona vasculata secreting glucocorticoids, but you can have overlaps also, especially when you have a primary adrenal cause for the cortisol excess. You can have also the glomerulosa secreting, you can also have the reticularis over secreting, and this applies especially or typically if you have an adrenal carcinoma, adrenocortical carcinoma. Then you can have primary adrenal insufficiency. And then amongst the when you talk of insufficiency, primary adrenal insufficiency will refer to pan-adrenal insufficiency. But you can have selective sort of deficiency of the fasciculator zone when you have some condition where there is resistance to the action of ACTH. Remember, the fasciculator or the glucocorticoid control is primarily under ACTH from the pituitary, whereas mineralocorticoid control is primarily by angiotensin 2. So you can have specific ACTH resistance causing cortisol deficiency, but no mineralocorticoid deficiency. You can have selective aldosterone deficiency without glucocorticoid deficiency, and then maybe something like pseudo hypoaldosteronism, which biochemically looks like hypoaldosteronism, but the aldosterone levels are normal. And then you can have a condition where you have both deficiency as well as excess secretion from the adrenal cortex, which is represented by congenital adrenal hyperplasia, where you have basically a deficiency of cortisol, which may or may not be clinically overt in a given individual, but there is excess secretion, most commonly of androgens, sometimes of mineralocorticoids as well. So that is a mixed situation, congenital adrenal hyperplasia. Quite often the presenting features are of androgen excess in clinical, as they present to us. The most common is in that way. It could be in a female, or it could be in a boy as well. And there is underlying cortisol deficiency as well. And then as we discussed, adrenal incidentaloma. However, for most clinicians, the most common adrenocortical disorder would be a secondary adrenocortical insufficiency, secondary to prolonged use of exogenous steroids. And this especially is become more a topical issue in the context of COVID, where people are put on and continued on glucocorticoids, maybe for relatively long periods of time. So we shall not talk of congenital adrenal hyperplasia at all anymore, because for our target audience, I don't think that's a topic that will be of great interest. Secondary adrenocortical insufficiency also I shall not discuss, but we can, I shall not have it as part of my presentation, but we can have discussions. So I'm starting with primary aldosteronism, PA, not because it's very common, but because there has been some changes in our understanding. I mean, Cushing's syndrome is generally thought to be the most common adrenocortical disorder. However, and in recent times, it has been found by looking at by proper evaluation of unselected patients with so-called essential hypertension, that significant number of them possibly have an underlying endocrine cause in the form of primary aldosteronism. So the prevalence amongst those with hypertension in the past was only considered about 0.5%, but these days there is a number of studies which suggest it may be as high as 10, and some even go to the extent of 20%. My personal belief is possibly we are, this 10%, even 10% figure is a bit too high, but there are studies to suggest that. Now, so the important point is, when should we as a clinician be alert to suspect primary aldosteronism, diagnose it, and give it the proper treatment? Because we do understand that high levels of aldosterone, just a second, please give me a second. It not only does cause hypertension, even beyond hypertension, it damages other, maybe the endothelium, it can damage the myocardium, it can damage the kidneys also. So there can be additional adverse effects. So it's important that we try and identify. Now, when and how do we suspect? Now, there is Endocrine Society guidelines, clinical practice guidelines, which may be a little bit biased, which would suggest that any patient with sustained hypertension should be considered for primary aldosteronism. But I don't think you and I would evaluate for primary aldosteronism for every patient with hypertension. So unless there's something beyond just sustained hypertension, I think I wouldn't evaluate for a primary aldosteronism, despite the American Endocrine Society clinical practice guideline. So the ones that I put in bold are possibly the areas where quite often we are not sort of alert enough, but we should be from now on. If you have resistant hypertension, we should be thinking of a secondary cause, including primary aldosteronism. And we remember the definition of resistant hypertension, that someone whose hypertension is not controlled despite being on at least 3 drugs, including a diuretic. Even if it's controlled, but the patient is already on 4 drugs, then you consider. If hypertension is associated with hypokalemia. Now, this is normally taken as the first indication for evaluation for primary aldosteronism. Now, this has deliberately been put towards the, not at the first, as a first point itself, because we want to emphasize that many patients with primary aldosteronism may not have hypokalemia. So not having hypokalemia, but having hypertension does not exclude an underlying cause as of primary aldosteronism. Then hypertension with an adrenal incidentaloma, hypertension with obstructive sleep apnea, hypertension with a family history of early onset hypertension, hypertension and family history of CVA at less than 40 years, and hypertensive first degree relatives of patients with primary aldosteronism. So these are the situations where we should not waste the opportunity to provide a specific diagnosis, underlying cause for hypertension, and thereby treat appropriately. So when we have identified a patient with hypertension who is at higher risk of having primary aldosteronism, what we do? The first test is an aldosterone to renin ratio. Now, there are various precautions, there are different specificities to go into how to collect the sample. But without going into that, what we look at aldosterone to renin ratio at when expressed in suitable units. If it is more than 30, then we have a high suspicion, especially if along with the aldosterone renin ratio, the aldosterone level itself is high, more than 15, and if the plasma renin activity is less than 1 nanogram per milliliter per hour. Nowadays, these figures for aldosterone-renin ratio and plasma aldosterone to have a suspicion for primary aldosteronism has been decreased to 20 for the ratio and to 10 for the aldosterone level itself. Now, if you have these figures, then of course you go on to the next step, that is to that's a confirmatory test. However, even if you do not have these values satisfied, but if you have a high clinical suspicion, for example, hypertension with spontaneous hypokalemia, or if the sampling method was not all right, if the results were not very conclusive, then even then, maybe we repeat the test, we reevaluate the patient. Now, what is the confirmatory test? The confirmatory test is to give a salt load, saline load, either oral salt over 3 days and collect urinary aldosterone over the third day of this salt loading. How much of salt? It's at about 5 grams of sodium, which is about 12.5 grams of salt per day for 3 days. But what we do in hospital is a shorter test, an IV saline load test. We infuse normal saline over 2 liters over 4 hours. Of course, we have to make sure that this patient blood pressure is not going sky high with this infusion of saline. And we have also got to observe carefully. And then we do another aldosterone level at the end of the test, either urinary aldosterone. The figures are different, but we most commonly look at the serum or plasma aldosterone at the end of this 4 hours of saline infusion. And then if the aldosterone is less than 5, then possibly we had a false positive aldosterone-renin ratio. If it is more than 20, then the likelihood of an aldosterone-producing adenoma is high. If it is between 5 and 20, then it could well be primary aldosteronism. Many of these cases would possibly be idiopathic sort of hyperplasia of the adrenal zona glomerulus leading to hyperaldosteronism, but not possibly a surgical cause. But once we have confirmed, we have to go on to an adrenal CT scan and make sure whether we want to offer surgery, if the patient is acceptable for surgery. If on CT scan, we have a tumor and the patient is young, the aldosterone levels are clearly high, more than 15 or even 10, they say, but I would say more than 15 or 20, and clear-cut evidence of a tumor on one side and the other side is normal, then you can go ahead and do a laparoscopic adrenalectomy. You can do an open adrenalectomy also, but laparoscopic is what is suggested these days. The issue is sometimes you have a bilateral disease, adrenal hyperplasia, and sometimes it is asymmetrical. On one side, the gland may look big, the other side may be only slightly big, it may not be picked up. So if you operate on the apparently bigger gland, you may not actually be curing that patient. So there comes the next step to decide which is the side which is over-secreting. But this is a difficult test we have found, and we cannot do ourselves. We usually take the help of the cardiologists. We do not quite have radiologists as yet who are so interested in doing an adrenal venous sampling. So you have to put in a catheter, go to the adrenal vein and collect a sample from there, also collect a sample from the inferior vena cava and look at the ratio of the aldosterone level and thereby decide which is, and we also look at the cortisol level, and we then decide which is the abnormal side and then decide whether we should be operating a surgery or offering a surgery or not. If the disease is found to be bilateral, then we are treating with mineralocorticoid receptor antagonists. Spironolactone is what we use most commonly, but in male subjects, especially because of its effect on the testosterone receptor, androgen receptor, inhibiting the androgen receptor as well, may give rise to feminizing signs like gynecomastia. So many men would not prefer to have it long term. And so maybe eplerenone would be a better choice, but clearly experience over the world and more so even with us is more with spironolactone. Then there would be people who would not desire surgery. Even then, of course, we have to provide them medical treatment. Even on unilateral disease, there may be individuals where patients do not desire surgery. We may still have to use medical treatment. Now, just a word about this aldosterone-renin ratio. Remember, aldosterone and renin are the two components that we measure, and then we look at the ratio. So there can be a number of factors which affect either the aldosterone level or the renin level. And so the eventual ratio may not be reliable. So one of the factors to consider is if the patient has already had hypertension and hypokalemia, and it's a spontaneous hypokalemia, let's assume for now, meaning not because of having diuretic or thiazides as part of the treatment for hypertension, this low potassium itself tends to suppress the secretion of aldosterone. So unless you correct the hypokalemia, you may have falsely low aldosterone level and therefore falsely low aldosterone-renin ratio. And then there are a number of antihypertensive drugs, of which the spironolactone or the mineralocorticoid receptor antagonists, they also tend to vitiate the results, and ideally they should be avoided for about 4 weeks. Nowadays they say, earlier they used to say at least stop for 6 weeks. If you have other drugs like ACE inhibitors, angiotensin receptor blockers, beta blockers, alpha-2 agonists, avoid for 2 weeks. However, in many a case, we find that it may not be possible to withdraw all these drugs. So what, let's say someone is already on ACE inhibitor. Now we can, even on the drug, go ahead and do the test. If the test comes out as positive, the aldosterone-renin ratio is high, then we are sure that we are on the right track and the patient is likely to having primary aldosteronism. If the ratio is not high enough, then we may have to repeat the test after stopping the drug for 2 weeks. That is because ACE inhibitors, ARB, beta blockers, they all work on the denominator part, primarily on the denominator part. There's different. The beta blockers work primarily on the denominator. ACE inhibitor, ARBs, they work on the numerator part of it. So if while on ACE or ARB, you get a positive ratio, then we are assured. If it's not a positive, it's not a high enough ratio, then we have to repeat. Now, we are treating individuals. It's not just for us making a diagnosis, but we have to keep the patient safe as well. And which are the antihypertensives that we can still continue? Well, typically it's hydralazine, verapamil, alpha blocker. These are the ones which are preferred while we are evaluating for primary aldosteronism. So this is what we were saying, that prevalence could be about 10% of hypertension population, even in general settings, not specialty settings. And the point that I was making, that only in 50% of patients with aldosterone producing adenomas do we get hypokalemia spontaneously. And even lower numbers in those with idiopathic hyperaldosteronism or idiopathic hyperplasia do we get a hypokalemia. And then we have already established that patients with primary aldosteronism have higher cardiovascular morbidity and mortality compared to age and sex matched patients with essential hypertension and similar blood pressure. So there's something extra that this high aldosterone is doing to our system. And we have our treatment, and we can assure them that the hypokalemia will improve, especially even with medical treatment. Blood pressure control may not achieve optimum normal level sometimes, because with long-standing hypertension, there are said to be irreversible changes having developed in the vessels. So the blood pressure is expected to come down, but we may not guarantee that you will become normotensive and you will come off all other drugs, or if you are offering surgery, or even if you are providing medical treatment, the patient may sometimes need to continue small doses of other agents as well, but definitely the number of drugs will be decreased. So now we turn attention to this gentleman. So we are done at this point of time with our primary aldosteronism. And we get this 50-year-old subject who was detected to have diabetes 4 years back, is also hypertensive for last 3 years, is on oral antidiabetics, antihypertensives, and statin, complaints of ill health, muscle cramps, and some difficulty in getting up. So if you look at this individual, you may have only a small suspicion if you just look at this profile view. If you then have a little bit of suspicion, only then would you like to have a close-up view. In any case, in most patients with diabetes and hypertension, you may not even strip the patient to look at the clinical features, but possibly we do see that there is some amount of sort of central obesity. The limbs tend to be thin. And then if you look closely, we find this wide striae, purple striae, which are a very typical sign in Cushing's syndrome. So then you get into your mode of trying to evaluate an underlying cause. So this is once again US Endocrine Society clinical practice guidelines. When do you suspect? We know the typical features are there, but there are certain features which are more specific for Cushing syndrome rather than simple obesity. We all know that obesity is so common, and so when do we suspect that this obese person may have Cushing syndrome? Of course, one of which is the typical centripetal or the central obesity, the limbs being relatively thin. Now, there are certain terminologies which talk of the discriminant index of the features. So if you have bruising or ecchymosis, the discriminant index is very high. Muscle weakness, hypertension, again, many obese adult individuals may also be hypertensive. Plethora, yes, but this may not be so easily evaluable, demonstrable in our not light-skinned individuals. Hirsutism, if it is present, yes. The purple striae, many people, obese people, especially obese and then losing some weight, tend to develop striae, but most of these striae are pale striae. Most of these are thin striae. So we insist that unless the striae are at least 1 centimeter, and unless they are of a reddish purple color, they are not likely related to Cushing syndrome. And in women, menstrual irregularity would be another factor. Truncal obesity, once again, comes relatively low in the discriminant index. So here the discriminant index is highest with bruising. And why is it different from simple obesity or exogenous obesity? Because the features here are because of glucocorticoid excess, and glucocorticoid has an anti-anabolic effect. So it causes protein breakdown and fat breakdown. But of course, this fat breakdown may be a misnomer, because there is fat deposition in some areas, whereas there is fat breakdown in other areas. But eventually, the differentiating point is largely based on its protein breakdown effect, so that you have a thin skin The positive likelihood ratio is very high. If you have osteoporosis because of the effect of glucocorticoid excess, if you have ecchymosis more than 2 in number, more than 1 centimeter, positive likelihood ratio is 4. If you have all three, thin skin, radiographic osteoporosis, and ecchymosis, then the probability of Cushing's is really high. So these are sort of the hard clinical signs to suspect Cushing's syndrome. So what do we do when we suspect someone with Cushing's? We, of course, look at the basal cortisol. And we, in our department, of course, because we have facilities for doing ACTH assay, we quite often try and do the two together. Why do we do a basal cortisol? Because many cases are because of exogenous steroid intake, and in which case the basal cortisol will be low, suppressed. So patient is Cushingoid, but the cortisol is suppressed. We need not blame the laboratory. We need to blame ourselves if we have not taken the history of exogenous steroid intake, which sometimes the patient even may not be aware of. Patient may be on some homeopath, some Ayurvedic preparation, which may be having some form of glucocorticoid. And the ACTH level is also low in those instances. So the first step is to exclude exogenous Cushing syndrome, because that's the most common cause of Cushing syndrome. Second step is to confirm endogenous Cushing syndrome, for which we need to do any two of the following. However, this is all standard recommendation. In clinical practice, I would quite often do only one if otherwise a clinical suspicion is very clear. If it's an open and shut case of Cushing syndrome, then we may not do two of these tests, because it's always it's difficult for us to go for tests again and again, to spend more money. And so the tests are 1 milligram overnight dexamethasone suppression test. So midnight, you take 1 milligram of dexamethasone. Most commonly, the 0.5 milligram tablets are available. So 2 tablets, previous midnight, 11 to 12 midnight, 11 p.m. to 12 midnight. And next morning between 8 and 9, collect the blood sample. If the cortisol level is above 1.8 microgram per deciliter, then it is supportive of a diagnosis of endogenous glucocorticoid excess, or a prolonged test, which is a 48-hour test, 2 milligram per day, that is 0.5 milligram 6 hourly for 48 hours, low dose dexamethasone suppression test. The value, the cutoff value is similar to the 1 milligram overnight dexamethasone suppression test. Late night salivary cortisol, at least 2 measurements, and we have the specific figure. We still are not very acquainted with these tests. Our assay system does not allow us to do the salivary cortisol freely. Urinary free cortisol and creatinine should be simultaneously measured to ensure completeness of collection of urine sample. That's 24 hours urine collection. More than upper limit of normal, the higher it is, of course, the more confirmatory it is. The other is midnight serum cortisol, which quite often we take recourse to, especially if we have got a patient admitted in the ward. And the cutoffs are different because, cortisol is also a stress hormone. So if the patient is awake and you are fiddling to get his or her vein, then the cortisol level tends to be a little bit high. The principle of the test is, of course, normally there is a diurnal rhythm and the lowest levels of cortisol are at night. And if the values are above 1.8, if the patient is asleep, and typically we do not recommend it to be done on the first day the patient is hospitalized, because the patient is in a new environment, at least on the second or third day. It's best to have a cannula indwelling, maybe put in the evening itself, not fiddling with the vein at the middle of the night, so that patient is asleep. But even if awake, the cutoff figure is somewhat higher if it's above 7 microgram per deciliter. So these are all, any two of these, if you are satisfied. So most commonly, possibly 1 milligram overnight dexamethasone, that's as a outpatients, we would do this test. And as inpatients, possibly we will do a midnight serum cortisol. This is most common way that we approach in the hospital. And then we need to decide whether this hypercortisolism is ACTH dependent or not. And for which we need to do the ACTH sampling. So as we said, if we give exogenous dexamethasone, which is a long-acting steroid, the effect persists maybe a little while longer even after we stop the steroid. So if you are looking, maybe we have done a 2 milligram 48-hour low-dose dexamethasone suppression test, and the very next morning, if you're doing an ACTH sampling, it may still be on the lower side. So it may be pragmatic and useful to do the ACTH level straight away in the first step itself along with the cortisol. But if you're doing later, it may be best to allow another couple of days after completion of a low-dose dexamethasone suppression test and then do the ACTH and decide whether the ACTH excess is driving this cortisol excess or not. Now, theoretically, it stands to reason that if you have a primary adrenal cause of Cushing syndrome, then this high steroid will suppress the ACTH, so you will have low ACTH. Whereas if you have a pituitary or an ectopic ACTH secreting lesion, then the ACTH level will be higher. In clinical practice, quite often, this does not work out. We quite often have relatively gray zones, but nonetheless, if the ACTH level is less than 5 picogram per ml, then we take it that this is an adrenal Cushing's. If it is above 30 picogram per ml, we take it as ACTH dependent Cushing's. Between 5 and 30, you can have either, but anything above 5, we have a high suspicion of Cushing's disease anyway, because Cushing's disease is more common than the other causes of Cushing's. And of course, when we have high ACTH, the higher it is, the more likely is it to be an ectopic source rather than an eutopic or pituitary dependent ACTH. So this is a lady who has maybe some rounding of the face, plethora possibly is there. She's hypertensive, she's diabetic. The blood pressures are quite high on amlodipine 10 milligram, and she has got hypokalemia, potassium is 2.7. The basal cortisol is very high, 35 microgram per deciliter. The usual upper limit is possibly, if you look at the range, maybe 25 microgram. Overnight, dexamethasone suppressed cortisol is quite high. Remember, the cutoff was 1.8, it is 22. Low dose dexamethasone suppressed cortisol is again quite high, 25. The ACTH is less than 5, which all now satisfies our criteria for an adrenal-based Cushing's disease, Cushing syndrome. We also look at dehydroepiandrosterone. We also look at aldosterone levels, which we may not go into the details of right now. But this, at this point of time, when we think of an adrenal-based lesion, we would do an adrenal imaging. Adrenal CT scan most of the time is good enough. And here we can see on the right side a definite lesion and SOL in the right adrenal region. We try also to look at the left adrenal and find out if that is also enlarged. Of course, in the same cut, you may not be able to appreciate both the adrenal glands. And we would be happy if we cannot see the left adrenal, or if we can see that it's clearly atrophied, then it clearly suggests that the disease is localized to the right side. And because of the high levels of cortisol, it has suppressed the ACTH. And so the other normal adrenal gland is suppressed. So if the ACTH is less than 5, then we go for CT scan of adrenal. And our interpretation will be either an adrenocortical adenoma or a carcinoma. There are of course, radiological indicators of what is likely to be a carcinoma versus adenoma if we get a unilateral mass. If there is not clear mass, but the adrenals are enlarged, largely preserving the shape of the adrenal glands, then possibly it's a macronodular adrenal hyperplasia. If the adrenals are normal or minimally enlarged adrenals, then this is something called primary pigmented nodular adrenocortical disease. So all these are if the ACTH is under 5 picogram per ml. So these are the primary adrenal causes of cortisol excess. If it's more than 30, then we go to a dynamic contrast MRI scan of the hypothalamo-pituitary region and requesting for thin slices, thin cuts as well, because the pituitary based lesions causing Cushing's disease are typically microadenomas. They are not big lesions typically. And we also do the high dose dexamethasone suppression test. Possibly we do the high dose dexamethasone suppression test and then we do the MRI scan. If we find a lesion on the pituitary which is more than 6 millimeters, if there is more than 50% suppression in high dose dexamethasone suppression test, if the potassium bicarbonate are all normal, AVP test is something that we do not commonly do, but if you can do, and if it's a positive AVP test, then we fairly confidently diagnose that it is this small lesion in the pituitary that is the cause of the abnormality. If, however, there's some discordance, then we need to go into a more difficult test, the inferior petrosal sinus sampling, which tries to define whether the cortisol or the ACTH excess is coming from the pituitary or from the rest of the body. And we sometimes need to do also a Dotanoc PET CT to look at small lesions in the pituitary, because if the adenoma is, if the pituitary lesion is less than 6 millimeters, sometimes it may just be an incidentalloma, not a causative lesion. So, but if we do have a Dotanoc positivity at that lesion that we have shown on MRI, then it more or less suggests that that is the causative culprit lesion in the pituitary. For ACTH values between 5 and 30, we are a little bit on difficult ground. We have to do the same set of tests and try and find out how it matches. And there is also a condition of cyclical Cushing's, so that sometimes you may have confusing blood reports which are not congruous, and we may have to follow up. Now, this is a 43-year-old lady who is uncontrolled diabetes, uncontrolled hypertension, 5 years. For 5 years, she's on 3 drugs, including hydrochlorothiazide. Her potassium is clearly low. Cortisol, basal cortisol is not clearly high, but at least it excludes exogenous Cushing's. Her overnight dexamethasone suppressed cortisol is still high. Midnight sleeping cortisol is high. Morning ACTH is clearly high, more than it's 109 picogram per ml. And post high dose dexamethasone suppression test, there is more than 50% suppression. From 23.9, it's become 4 microgram per deciliter. This all suggests that the excess ACTH is coming from the pituitary, and we did the imaging, and unlike what I have said, that mostly it's a microadenoma, here we have a big dumbbell-shaped tumor, a macroadenoma in the pituitary, which is the cause of the Cushing's syndrome. So how do we differentiate between eutopic and ectopic source of ACTH? We did suggest the absolute value of ACTH may sometimes help. But clinical setting is extremely important. We remember that in ectopic ACTH syndrome, the patients quite often do not have the full-blown clinical features of Cushing syndrome. They have more of biochemical abnormalities. They more have hypokalemic alkalosis. But the typical Cushingoid, the rounded faces, the plethora, the central opacity quite often are not there. And because underlying cause may be a malignancy, the patients may actually be a relatively wasted and thin person. Clinical signs are less other than myopathy. Myopathy is predominant in these patients. However, we have to remember whenever we see an ACTH-dependent Cushing syndrome, more often than not, it is a Cushing's disease, a pituitary-based Cushing's disease, because ectopic Cushing's is overall much less common. And so whenever we have ACTH Cushing syndrome, quite often we can straight away go to MRI scan of the hypothalamo-pituitary region with or without a high-dose dexamethasone suppression test. And we do remember that the MRI scan doesn't have 100% sensitivity even. So very small lesions on the in the pituitary may not be picked up on MRI. So just having a negative pituitary MRI does not exclude the diagnosis of Cushing's disease. Patients are more often than not likely to still harbor a small adenoma that has not been picked up on the MRI. On the other hand, if you have hypokalemic alkalosis, then the patient is more likely to have ectopic Cushing's disease, which of course should not mean that patients with Cushing's disease with pituitary microadenoma cannot have. Even they can have, but the possibilities or chances are less. So with these, we also come to this patient, 50-year-old, severe proximal weakness, weight loss, very low potassium, 1.9. Clear alkalosis is there, pH 7.58, PCO2 is on the lower side, basal cortisol very high, overnight dexamethasone suppressed cortisol very high, urinary free cortisol UFC is very high. The normal is about 50 to 100 micrograms per day. This is 300, and the ACTH is very high, 236. And this is just to show that chemosis or conjunctival edema could well be a clinical sign of Cushing's syndrome. So this is going to the bedside once more, and these subtle signs, because otherwise you cannot, by looking at this patient, make out that this patient is having underlying Cushing syndrome. So this could be a subtle sign, and this patient had, on the basis of these reports, and because in a middle-aged male, the most common is an lung carcinoma. So a chest X-ray was also done, and it showed a big lesion there. And on CT scan of the abdomen, what we did find was these are the adrenals. This is the right adrenal. And sorry, I'll use my pointer. This is the right adrenal, which is enlarged a little bit, bulky a little bit, but preserving the normal anatomy of the adrenal. And this is the left adrenal. So this is a case of ectopic ACTH syndrome because of a lung carcinoma. This is a radiological sort of feature of bilateral adrenal enlargement. This is the right one is small, the left one is huge, and see much of that has got very low HU on CT scan and suggesting presence of fat. And this is a case of bilateral adrenal myelolipoma. This patient, typically these are non-functioning tumors, but this patient also had Cushing's disease. The disease was, there was a pituitary microadenoma, but also had bilateral myelolipoma, not a common condition, but we can sometimes have. Next we come to, or shall we try and answer, it will become to the questions that we have in the chat box. Maybe clearly I'm coming to some questions in calculating plasma renin activity, or what the person meant, which is an anonymous attendee I find. Can amlodipine be continued? If not, why? Well, amlodipine may be continued, but better is verapamil, because amlodipine may give rise to elevation of the plasma renin activity. So the ratio, aldosterone to renin ratio, could be falsely low. So basically, we would prefer the amlodipine is a much preferred, much more commonly used antihypertensive rather than the verapamil. We would ideally like to change it to verapamil. Then Dr. Nilanjana Patro, how to start screen radiographic osteoporosis? Thank you. Right. So this is a good question, because by X-ray, you can see only very advanced osteoporosis. We in our institute, of course, do a DEXA BMD to look for osteoporosis. Even by doing a properly done X-ray, we may pick up osteoporosis, but only at an advanced stage. Can simple, and then Shampurna, Dr. Shampurna Chowdhury, can simple obesity and depression result in a false positive dexamethasone suppression test? Again, a very good question. Yes, depression can give a rise to a false positive test, non-suppressed test. Typically, in those instances, you sometimes can get away by looking at the diurnal variation in cortisol levels. In Cushing's syndrome, the diurnal level is lost. In depression, still mostly it is preserved, but it is not foolproof. Sometimes we have to do we do not have CRH. We have to do based on continuous dexamethasone suppression test followed by a CRH stimulation test. Since we do not have CRH, we sometimes use AVP as the stimulant. So now we turn our attention. We'll of course come back to the questions and to the chat box later on. So we now come to adrenocortical insufficiency. Of course, if you have features of adrenocortical insufficiency in the acute setting, sometimes you may not, it's difficult to pick up in the acute setting, especially because there are so many other things going the patient, you may not think of adrenocortical insufficiency, but the symptoms are typically related to cortisol deficiency, mineralocorticoid deficiency, and so what you have is volume depletion, hypotension, some dehydration, there is hyponatremia, there is hyperkalemia, and you can have non-specific weakness, tiredness, you can have slow-grade fever, you can have some amount of abdominal pain, hyperpigmentation, and in children, you can have hypoglycemia as a presenting feature. So these are the symptoms of primary adrenal insufficiency: weakness, tiredness, fatigue, invariably, anorexia, very commonly. Other GI symptoms, nausea, vomiting, are very common. So the GI symptoms and weakness, tiredness. So many a time you may be led into thinking of a primary GI cause, but if you are attentive enough and if you do your tests, then you may find adrenocortical insufficiency, which is relatively easy to treat and is very rewarding. So you can have also abdominal pain. Let me remind you: diarrhea, salt craving, postural dizziness, weight loss, hyperpigmentation does happen quite often. That is primary adrenal insufficiency, low blood pressures, but quite often the patient may not have clearly low blood pressure, but patient may have postural drop in blood pressure. Vitiligo may be there, not as feature of primary adrenocortical insufficiency, but if you have an underlying autoimmune cause for adrenocortical insufficiency, then vitiligo is another sign of autoimmune disease. Auricular calcification may be there, and amongst the electrolyte disturbance, most common is hyponatremia. Hyperkalemia is also very common. So both of these should be looked for. Sometimes there is hypercalcemia, uncommonly, not typically primarily a feature of glucocorticoid or mineralocorticoid deficiency. You can have anemia, azotemia, and eosinophilia. We do look for, because we know cortisol otherwise helps to sort of decrease the eosinophil levels. And so if you have low cortisol, you can have eosinophilia. The point here that was being made is hyperkalemia is not invariable. So if you do not have hyperkalemia, don't be afraid. We see so many patients of primary adrenocortical insufficiency who do not have hyperkalemia. This is just because we saw a patient of secondary adrenal insufficiency in this patient who had auricular calcification, whether this is shown very easily, clearly visible or not. So auricular calcification, while it's described in primary, we have seen in secondary adrenal insufficiency. And here we are talking of secondary because you can see the pituitary gland is very small here. So how to screen? Screening, first of all, is a basal cortisol. So though we have written 250 microgram of cosintropin or IV corticotropin, first is, of course, a basal cortisol. If you have the opportunity and the patient is not so ill, then you look at the figure. If the value is less than 5 microgram per deciliter, then I don't think you need to sort of do the stimulation test. However, when you have a doubt, then you can do a stimulation test, which tells us the adrenocortical reserve of secretion of cortisol. So you inject 250 microgram cosintropin, which, however, is not widely easily available. And this costs a lot. The cortisol assay will cost maybe 400 or 500 rupees, but the cosintropin, synactin, may be charged, the shops would charge maybe 2,000, 3,000 rupees. And many a time you have to go from one shop to another before you get it. But fortunately, in future, we have made one of the big pharma companies agree to make cosintropin in our country and have it more freely available. So maybe in the next few months, this will be available. So if the patient's cortisol after this acetate stimulation at 30 or 60 minutes, maybe best to do both at 30 and 60 minutes because you do not always know when the peak will come. The patient passes the test if the cortisol is above 18, anything less is insufficient response. So as I said, in many cases, clearly cortisol less than 5 is good enough. In patients with confirmed cortisol deficiency, plasma ACTH twofold the upper limit of normal, typically above 100, is consistent with primary adrenocortical insufficiency. And if the baseline ACTH is more than 300, then it is already exerting maximum stimulation of the adrenals. And so no need to do this short synactin test, this 250 microgram business. You may not do if you already have a cortisol less than 5, ACTH more than 300. If the baseline cortisol is more than 10 itself, the chances of adrenocortical insufficiency are less. If it's above 15, it is even more unlikely. Of course, we are not talking of the acute setting or the ITU setting where you still may have adrenocortical insufficiency even if the baseline cortisol is higher than this. If you want to be proper, one should ideally also do plasma, renin, and aldosterone in primary adrenocortical insufficiency to determine whether mineralocorticoids are also deficient, but that clearly adds to the cost burden on the patient. And again, renin, aldosterone are not easily done, are not done by any of the laboratories here. In Kolkata, we have to send off the sample to Bombay or Delhi or other places. This is an issue that we wish to highlight, that this is a patient who actually had pulmonary histoplasmosis, also had bilateral adrenal, huge, significant enlargement of the adrenals, whose cortisol level initially were normal, was about 13 or 14 micrograms per deciliter, but the ACTH was elevated up around 105 or 110 picogram per ml. Now, these individuals may or may not need cortisol replacement at this point of time, if you can clearly follow them up. So there is also something like subclinical adrenocortical insufficiency. So it's not always black and white. There are various shades of gray in between. These are rare instances.
তুমি আনমিউট করো তোমার সাউন্ড হচ্ছে না শুভঙ্কর।
Right. Oh, okay. Yeah. Thank you. So very low cortisol, very high ACTH, and we tend to exclude congenital adrenal hyperplasia in these instances. And the 17-hydroxyprogesterone is your clue. It is not elevated. Potassium is normal. Plasma renin activity is normal, which suggests that you have only cortisol deficiency, but we do not have mineralocorticoid deficiency. If you had mineralocorticoid deficiency, the plasma renin activity would have been high, the potassium would have been high. So this is a rare case of, let's say, familial glucocorticoid resistance syndrome, where you have actually familial glucocorticoid deficiency because of ACTH resistance at the level of the adrenal cortex, where the mineralocorticoids are not affected. But this is a rare condition, but also a form of adrenocortical insufficiency where only cortisol is affected. This is another example. We won't go into the details. And this is, again, a rare condition, the AAA syndrome, where achalasia, and we have got this barium swallow showing the typical deformity at the end of the esophagus, suggesting achalasia of the esophagus. Alacrima, meaning lack of tearing. The child is crying, but no tear drops are seen, and associated adrenal failure. And then, of course, you can have different combinations. Sometimes you can have only two of them, not all of them. And then you can have the quadruple A rather than AAA, where there is additional autonomic failure. Then, while on the issue of adrenocortical insufficiency, we have rare causes. The polyglandular autoimmune syndromes, type 1, especially is associated with adrenocortical insufficiency. And here is a child of 6 years who presented with painful muscle spasms. He had this mucocutaneous candidiasis, the nail changes because of candidiasis, because of autoimmune polyglandular syndrome type 1, where the three components are the three classical components are mucocutaneous candidiasis, which manifests first, typically within the first 5 years. Then you have hypoparathyroidism, and it's the consequence of the hypoparathyroidism, the hypocalcemia, that the child was getting these spasms. Muscle spasms can have something like convulsion as well because of hypocalcemia, which usually or typically presents within the first 10 years of life. And then you can have adrenocortical insufficiency, which usually tends to develop a bit later, but usually within 15 years of life. So this is a rare syndrome. And then you can have presentation as PUO as because of primary adrenocortical insufficiency itself, but in this particular instance, who presented with this neck swelling, sort of maybe something like a cold abscess over there, and markedly enlarged bilateral adrenal glands, which are not taking up the contrast, and with low attenuation. This was a case of adrenal more of a disseminated actually histoplasmosis, where of course the PUO could be because of the fungal infection, or it could be because of adrenocortical insufficiency as well. And here are the histoplasma being shown in this aspirate from the neck lesion. And this is yet another instance, more recent we saw recently, and these are the adrenal glands, and this is the calcification within the adrenal gland. And this is after, this is a year back, and this is the latest is about only in July 2021. So more than a year's treatment with itraconazole. However, what we see is that the adrenal glands quite often do not shrink significantly in size. Maybe now the gland has developed calcification even on the right side, on the left side, whereas previously here we do not see an adrenal, Here we do not see any calcification on the left side. However, in the latest film, we do see some calcification on the left side as well. So adrenal histoplasmosis could be part of disseminated histoplasmosis, but most of the time when the patient comes to us, we often do not see much evidence of pulmonary histoplasmosis along with it. This is something that we all need to remember. This 46-year-old man presented with fatigue, lethargy, weight loss since last several years, recurrent episodes of nausea, vomiting, hospitalization with hyponatremia, and each time he had saline, sometimes he had hypertonic saline, he got better, went back home. But we need to remember that these could be where we do not see the pigmentation that we associated with primary adrenocortical insufficiency. Here we have to keep our suspicion high for secondary adrenocortical insufficiency, and this patient was evaluated, the cortisol was low, so were the other pituitary hormones patients. Testosterone was low, FSH, LH were low, and he was also having central hypothyroidism. So when we detect hyponatremia and we have guidelines as how to approach, remember that before we embark on other evaluations, we have to make sure that the patient does not have adrenal, thyroid, pituitary, or renal insufficiency. So remember, adrenal and pituitary causes of hyponatremia are there. And so here, treatment with replacement. So he was treated with glucocorticoid, treated with thyroxine, treated with testosterone. And this is a picture, of course, here. There is some suggestion that maybe he has been over-treated with glucocorticoids and has developed some amount of moaning. The dose has to be adjusted. So finally, I'd like to end with a word about adrenal incidentaloma. Prevalence about 40% of imaging of the abdomen being done. It's more common if you are looking at people, let's say, above 50 years, in general, more common in women. By the term incidentaloma, we tend to mean that the patient, the adrenal is not functionally active, but many a time we find that they may have subclinical or not clearly yet identified functional disease of the adrenal cortex as well. And it may not now only be the cortex, it could be the medulla as well. So it is a dictum that whenever an adrenal incidentaloma is detected, we need to exclude underlying functionality. And of course, we need to exclude whether it's malignant. And depending on that comes the next step of whether that adrenal needs to be removed, or we can just follow up the patient. And of the functional adrenal lesions, of course, the most serious is the one that produces the catecholamines, that is pheochromocytoma or paraganglioma. And so 24 hours urinary metanephrines or plasma metanephrines should be done in all these cases, especially or even without, whether we are going to decide what will our next step be. We also do an overnight dexamethasone suppression test because about 20 to 30% of these incidental rumors may have subclinical Cushing syndrome. Aldosterone-renin ratio should also be done, especially if the patient is hypertensive. We also do a DHES. And then, of course, we have to decide based on radiological criteria whether the lesion is likely to be malignant. So with this, I think I come to the end of my presentation, which would hopefully establish that adrenocortical diseases can have multisystemic presentation. We have to have a high clinical suspicion. We need to have a stepwise approach and keep in mind the possible pitfalls and confounders. And we also know about adrenal incidental rumors. So maybe it's over to the chairperson, and maybe I'll also have a look at the questions. So.
Hello. Yes. Hello. It's been a wonderful journey for about 1 hour, 10 minutes from a master person taking cognizance which point has to be omitted, and when particularly during diagnosis which step may be omitted. This is a wisdom. So I hope everyone has enlightened. Now we can move to some question waiting in the chat box. Particularly,
yes, there are a lot of questions I can see. And would the organizers tell us what is the cutoff time? When do we have to sign off? I shall try and answer.
Subhankar, you proceed on the questions. Possibly there are not so many questions, but you try to go through all the questions.
Okay, fine. So let's see. So Anamika Bhadro, Dr. Anamika Bhadro, kindly repeat the case of 46-year-old man of hyponatremia. This gentleman presented with recurrent episodes of nausea, vomiting to different hospitals, and was in some hospitals even without doing any tests. He was given saline and he got better. So the point that I was trying to stress is that this hyponatremia, the underlying cause was not addressed. Immediate treatment was provided. The patient got better and went home. So pituitary hypopituitarism may present in this way. And in this particular instance, remember, actually, which I did not discuss, this patient has post-snake bite hypopituitarism, has a history of viperoid snake bite several years back. And following that, he has had developed hypopituitarism, which he or the treating physicians were not aware of. I'm coming to so value of random cortisol in critical care. It is there. The cutoff values are clearly much higher to decide on whether there is deficiency. So unless the value is, if the values are even at 20, patient may still not be having, may still be having adrenocortical insufficiency. So the cutoff values are significantly higher. So PPAL, why there is pronounced hypokalemia in ectopic acetate and utopic, is there a particular reason? The reason essentially is because, as we said, though this is not an absolute differentiating point, the ACTH levels are much higher in ectopic ACTH syndromes because they are more often of malignant tumor origin. And the higher ACTH, the higher cortisol, the higher effect, because glucocorticoids also have a mineralocorticoid effect, mineralocorticoid-like effect, and that effect is to cause excretion, to retain sodium and to excrete potassium. So they tend to have more hypokalemia. And I'm going up, and which are the other questions? Dr. Shivendu Ghosh, treatment of hypothalamo-pituitary adrenal axis, suppression of prolonged steroid, that is really very, very important, fairly big chapter. By and large, we if we want to make things relatively simple, if someone is on less than 7.5 milligrams of prednisolone, the chances of prolonged suppression of the hypothalamo-pituitary adrenal axis are small. Having said that, there is significant individual difference. And if the duration of exposure to the steroids, even higher doses, is less than 3 weeks, the chances of long-term suppression are less. So less than 7.5 milligrams of prednisolone or its equivalent, less than 3 weeks of exposure to steroids, we usually do not bother about suppression. Anything beyond that, we have to be concerned. And the way that we can go about it is first try and get the dose within sort of the physiological. So 7.5 milligram of prednisolone is roughly equivalent to the physiological release of cortisol by the adrenal cortex in a day. It's not exact though, and prednisolone has a longer half-life compared to endogenous cortisol itself. So wherever the clinical condition, if the patient has already got suppressed cortisol, if the clinical condition would permit, then we would now try and get the steroid level down to at least about 7.5 milligram or thereabouts of prednisolone equivalent. And this decrease has to be slow. Sometimes we try and after we have come to about 7.5, so this has to be slow. So how slow will partly be determined by the underlying clinical condition. If you decrease the dose by a certain amount and find there is flare up of the underlying disease condition, then of course you have to go back. So by trial and error method, and you do not decrease the dose by any faster than in a week, but preferably even no faster than a month, the decrease in dose. So we have to have patience. It has to be done slowly. And when we have reached about 7.5 milligram of prednisolone, we would prefer then to go to the shorter acting hydrocortisone and give an equivalent dose of about 10 milligram of hydrocortisone, or maybe 10 milligram in the morning and about 5 milligram in the afternoon. Why? Because the shorter acting agent will less likely lead to long time suppression of the hypothalamo-pituitary adrenal axis. And then after about a month or two of this, we try and look at the morning cortisol level, whether it is still suppressed or not. Only after we have changed over to hydrocortisone in physiological replacement dose do we then, and being on it for at least a couple of months or thereabouts, we try and see if the morning cortisol has come back. If it has come back, then we can withdraw. And what is come back, at least the morning cortisol level of 10 micrograms per deciliter would more or less assure us. However, even then, ideally, at that point of time, we should be doing an ACTH stimulation test, like the one we suggested, and see if the patient can respond normally. Means the cortisol can rise above 18. If the patient can rise above, can show a cortisol response more than 18, then we can remove hydrocortisone and fairly assure that you do not even need stress dose of cortisol. But in many a time, we would possibly still be careful enough and suggest that even in stress situation, you may require and should have. So this is about prolonged suppression. The other is Dr. P. Pal discussed the role of, and there is also Dr. Anamika Bhadro discussed about the role of AVP. So AVP sort of stimulates, like CRH, there is AVP receptor on the pituitary corticotrophs. So it also stimulates ACTH. So we can use AVP because CRH, corticotropin releasing hormone, is not available to us widely. So we can use AVP as a surrogate for a CRH and use for stimulation. And the principle for its use in Cushing's syndrome is that in Cushing's disease, where the pituitary itself is producing the ACTH and stimulating the cortisol, there is some amount of physiological relationship still present, in contradistinction to an ectopic ACTH syndrome, where there is absolutely uncontrolled amount of ACTH secreted, which is not under physiological control at all. So in the pituitary ACTH excess conditions, if you stimulate it further, then there will be some stimulation of the ACTH from the pituitary, but it will not affect an ectopic source of ACTH. Having said that, here what we refer to as ectopic ACTH, most commonly we mean a malignant source of ectopic ACTH, but there are some forms of carcinoid tumors which are not grossly or clearly malignant, sort of something between benign and malignant. Even they could respond to this AVP and produce a picture similar to an endogenous or eutopic source of ACTH excess. So there is a question: is there any criteria to differentiate iatrogenic form of increased cortisol products from the body? I didn't understand. So if you have iatrogenic steroids, typically this is not cortisol itself that is given. It's usually dexamethasone, betamethasone, prednisolone, etc. So they will not be measured as cortisol itself. Dexamethasone, betamethasone, they are absolutely different. Prednisolone does have, in the assays that we use to measure cortisol, has some cross reaction with cortisol, maybe about 10-15% cross, even 20% cross reactivity with cortisol. However, because of its higher potency, the amount of prednisolone that one would be given is relatively small. So the actual assay interference with cortisol measurement is also quite small. So that's about what I had to say. And again, another very clinically pertinent question from Dr. Shubhendu Ghosh: can we do imaging early than the sampling, which is so much complicated, particularly in hypertension and hypokalemia? Yes and no, we can, but as we understand, especially in elderly people, we can, the chances of having an adrenal incidentaloma are much higher. So if you look in someone with hypertension and hypokalemia, if you get an adrenal lesion, it does not automatically pinpoint that the adrenal is the source. It could just be an incidentaloma. That could be some other cause. So it's ideal possibly to do it stepwise, but sometimes we may have to do so. Right, and now can we look at more? Dexamethasone suppressible CRH simulation test, any role in the diagnosis? Yes, it has role in the diagnosis, especially in those like the other causes which could give a Cushingoid sort of picture, especially in depression, alcoholism, and so on. Now we have Dr. Jaydeep Ghosh. We had a patient of adrenal incidentaloma, high basal cortisol, high midnight cortisol, and high ONDST, plasma stage 49.9. LDDST only showed greater than 50% suppression, HTC more so. Patient didn't suffer from fever, probably has sepsis for which she was treated. CT adrenal sensitive hematoma. What is the clinical impression from the suppression test? Can we please shed some light on it? Well, all of these should best be done when the patient is not in a stress situation. Sepsis, possibly we can have difficulty interpreting this test. So ideally, we would suggest that we repeat the test when the patient has come out of the sepsis. So clearly, if we have even an LDDST showing significant suppression, more than 50% suppression, though our cutoff after LDDST to define as normal is a cortisol less than 1.8 micrograms per deciliter. More than 50% suppression also sort of suggests that maybe the lesion is possibly in the pituitary. As we said, pituitary, MRI pituitary being normal does not exclude a pituitary microadenoma. The sensitivity of MRI is possibly about 60–70%. In the context of a sepsis, a hematoma in the adrenal, and I suppose it's an unilateral hematoma and it's not bilateral. So it could be related to whatever the hemostatic defects that may be there in a septic patient may have given rise to an unilateral adrenal lesion. And the ACTH level also being high, isn't that what we read? Plasma ACTH, 49.9 is not clearly high, but is suggests an ACTH dependent Cushing's process. So I would be more biased towards pituitary Cushing's in this individual. Also, because that is the most common cause for Cushing's syndrome. Of course, you have not had time to mention whether this patient had a Cushingoid feature overall or not. Dr. Taposh Bandyopadhyay, how to manage acute adrenal insufficiency in critically ill patient, when to suspect, and how to know acute or acute and chronic, as sometimes history not available. That's a difficult question, how to differentiate between acute versus chronic. Well, if you have a clear signs of hyperpigmentation, then it's likely a long-term process and it's likely to be chronic. And acute adrenal insufficiency in a critically ill patient is really difficult to suspect. Maybe some of the usual clinical pointers like persistent hypotension, not easily responding to fluid replacement would be one. And that apart, if you have a clinical background to give us a suspicion, for example, someone had undergone, is known to have undergone pituitary surgery, patient with snake bite history, significant snake bite history in the past. All these would be clinically relevant, but after all, I think our level of suspicion has to be high, because this is a situation where we can sort of save the life of the patient by a relatively simple means of providing the steroid that the patient is deficient in. I know this is not a satisfactory enough answer, but I think we have to do justice to whatever time we have left. For patients, Dr. Shikhar Ansal. Patients presenting with Addisonian crisis when we have already administered steroids and fluid at high doses, how and when should we check? Well, if you have used hydrocortisone, most likely in a crisis situation, hydrocortisone is the steroid that you would have used. Then when the patient is stable, you can stop 1 or 2 doses of the IV hydrocortisone and you can check for the cortisol. ITT in the diagnosis of adrenocortical insufficiency, anonymous attendee, yes, it does. The issue is insulin tolerance test. It causes hypoglycemia, and hypoglycemia then stimulates the pituitary to cause ACTH secretion, and then the ACTH will act on the cortisol, or will act on the adrenal cortex. Remember that if the patient has got adrenocortical insufficiency because of secondary cause, or even because of primary adrenal insufficiency, these patients may tolerate ITT poorly, more so in secondary adrenocortical insufficiency because of associated other hormonal deficiency. And this is not a pleasant test to do, so we quite often do not do it. And also it presupposes that your pituitary is normal. because you are making use of the pituitary to produce more ACTH to stimulate the adrenal cortex. More direct test would be the ACTH stimulation test to stimulate the adrenal gland. Next, Dr. Anindita Dotto, based on clinical features, exogenous and endogenous Cushing's can be differentiated. Yes, based on clinical differentiation and clinical features, we do try, first of all, the history of steroids, and quite often the patients do not come up with an answer that I'm taking steroids, but sometimes pressing on and asking whether you're being treated for any chronic condition. Sometimes patient would not remember, may be taking something for the last several years because someone suggested, because he or she was lean, was feeling weak, was giving something because of chronic skin condition, chronic joint condition. These are the common clinical scenarios where patients are given steroids by whoever, I mean, not established practitioners of modern medicine. So that's one, but remember once again that many a time, even after asking for several times, the patient may not come up. And in terms of the clinical features, there are certain features which are more common or typically seen with exogenous than with endogenous. And these are the exogenous would tend to cause or may cause cataracts, for example, which endogenous steroid excess does not cause. Hypertension is more likely in endogenous Cushing's. Features of hyperandrogenism, especially in females, would be more likely in endogenous Cushing's, not in exogenous. Rather on exogenous, the androgens will be suppressed because cortisol or the steroids also suppress FSH and LH, the gonadotropins are suppressed. And exogenous is always associated with suppressed ACTH, whereas this pigmentation that can be seen is more because of ACTH-like activity. So if you have pigmentation associated with Cushing's, then it is more likely to be endogenous. So there are a number of points, bits here and there, and then also aseptic necrosis of the femoral head. These are features more typically associated with exogenous Cushing's. There's another question also, again, exogenous endogenous Cushing's, which is of course of great clinical importance, especially for both MD and game trainees. Yeah, I think we have done a few, most of the questions I've taken. If there are some remaining, I may be pointed out.
Now,
Subhankar,
yeah.
may I ask one question?
Yes.
I have given a question, Subhankar.
Oh, Acha, I missed. Okay. Yeah.
Yeah. I'm
That's
Apurva speaking.
Yes.
Thank you
Yes,
for
Amrita.
the great lecture. It's really a master class. I put a question on the chat box. Is Sheehan syndrome is in your experience, and what should be a physician's approach?
Sheehan syndrome.
Yes.
Oh, okay. Yeah, you put right. Yeah, Sheehan syndrome is hypopituitarism, of course, a pan-hypopituitarism, and associated or resulting from postpartum hemorrhage. Unfortunately, if we scan our textbooks of endocrinology, we see very little written because these are Western textbooks. They have improved obstetric care and they do not see these cases of Sheehan syndrome anymore. We are also possibly getting better, and the numbers that we see nowadays are less than before, but still we do see. And the presentation quite often is late. The earliest features, of course, would be failure of lactation immediately after the childbirth. and then failure to resume the menses, the periods. But many people would continue life and would be diagnosed many years later.
Hello.
In our clinical scenario. Sometimes they would actually present with recurrent episodes of hyponatremia, hospitalized, treated, went back, and something like that. So we have, and the treatment results are very satisfactory. So essentially all the hormones, pituitary hormones, are deficient classically. Sometimes we can have partial also. So sometimes patients may have maybe the steroid part may be maintained, whereas thyroid, gonadotropin, growth hormone, all those would be deficient. Now, for the patients that come to us, we replace them with sex steroids if they are within their reproductive age group. Sometimes they come even maybe at later age. And we give them thyroxine, but before that we replace with steroid. We start with steroid and then give thyroxine, or we can give simultaneously as well, because the thyroxine takes a little while to act. So it doesn't matter, but if we only replace thyroxine and do not give the glucocorticoid, the patient may be pushed into adrenal failure. These patients are also deficient in growth hormone, and we read in text that growth hormone deficiency treatment leads to so much of improvement in quality of life and so on and so forth, but we can hardly give growth hormone to our growth hormone deficient children. We cannot give this give to these women, and who also typically who have neglected obstetric care, typically are from lower socioeconomic strata, so they cannot afford growth hormone treatment. Several years back, we had a publication in JIMA actually to look at the quality of life issues in the women with Sheehan syndrome who were replaced only with sex steroids, thyroxine, and glucocorticoids. And we found that most patients were quite happy. I mean, they didn't have major quality of life issues. So whether this is pharma generated information, we have our own doubts. So growth hormone may or may not be needed. Now, hypopituitary cause of adrenal insufficiency, we did talk of cortisol being the most important hormone being deficient. Then, but we also remember that ACTH also stimulates to an extent the androgen secreting cells in the adrenal cortex. So these individuals are also deficient in dehydroepiandrosterone. And there are some studies which suggest that maybe DHEAS replacement could also help them improve their quality of life. So Apurva, whether it satisfies or you had something else in mind?
It's quite satisfactory. Thank you.